So for those of you who are on, I welcome you. I'm Marion Dry, co-chair with Jonathan Sprague of ClassACT. And thank you all for joining us on the call. First of all, I hope that you and all your loved ones are well and safe and will remain so. We're really grateful to our classmate Jono for sharing his expertise with us this evening. Before I introduce him, I want to go over a few practical matters. As you've already noticed, everybody on the call except for Jono, and I will soon also be muted for the duration of the call. That's in order to make it work seamlessly, and because we're going to be a group of between 80 and 90. Jono will be answering questions after each of the three topics he presents. If you have a question for Jono, please use the chat function on Zoom, which you'll see in the lower bar. You can see chat. If you click on that, it'll open it up for you and you can type your question. In the upper right corner of your screen, you'll see either gallery or speaker view. If you click on speaker, you will just see Jono as he's speaking, and so you'll be able to have a better view of him as he talks to us. This event is being recorded, and we will post it on the ClassACT website as soon as we can so that we can share it and you can share it more fully. So Jono is an internationally known global health leader, and he's the author of The End of Epidemics, The Looming Threat to Humanity and How to Stop It. That was published in 2018 by St. Martin's Press and Scribe Publications. Jono has been interviewed by both North American and European mass media during the current COVID-19 global epidemic. A family physician and health management specialist, Jono is currently a senior fellow at Management Sciences for Health, where he previously served as president and chief executive officer from 2004 to 2017. He has also served as director of essential medicines at the World Health Organization. Jono is currently on the faculty of the Duke Global Health Institute, Harvard Medical School, and Boston University School of Public Health, and he's a past fellow of the Royal Society of Medicine. Jono, with gratitude, I turn the meeting over to you.
Okay, all right. Thank you, Marion, and thank you everyone for signing on. It's usually good to see classmates. I wish we hadn't been brought together by this. The book I wrote in 2018 talked about this sort of pandemic and described the possibilities in some pretty vivid way. But I mean, I'm just finding it chillingly surrealistic to see what's actually unfolded. And in some ways, everything that experts have been predicting and warning about for a long time, and yet sort of so many just totally unexpected things. I want to start by just paying a real huge debt of gratitude to all the health workers who are putting themselves in the front lines here in the U.S. and around the world. I mean, they are our frontline defense, and I think it's those health workers who, not always with all of what they need, are taking care of the sickest and the most vulnerable. So I think we all owe them a debt of gratitude going forward. So we're going to deal with three questions. We're going to talk about where we are now overall, just globally and actually with the epidemic, how and why we got here, and what's next and what we might do in the future. I'm going to pause to answer some questions, and I think it's because you haven't heard exactly what's coming. I want to try to make it so that we don't easily as possible. So as we all know, this came out of China, first developed first identified first cases. Now we know we're in December. And this virus is out of the coronavirus family, which is quite a mixed family. There's 7 coronaviruses that are in humans. 4 of them are basically simple cold viruses, and 3 of them have gone global, viruses that have gone global. The first one was in 2003, SARS out of China, a very similar sort of outbreak. It's a virus that tends to live in bats and gets into, through droppings or other ways, gets into animals, and these are animals that are sold in live animal markets, wet markets, and that outbreak went global. That was the first one. Second one was a virus, MERS from the Middle East, and then this one. So now, within a matter of barely 3 months, we've got 360,000 cases worldwide, over 16,000 deaths. It's hit 163 countries, and it started explosively in China, and through, as we hear in the news, draconian action. They actually have brought it down and are down from where at one point it was 4,000 cases a day. Now they're down to only a few hundred new cases a day. It then got into Asia, particularly into South Korea, which had a big outbreak. But then it came into Europe, so it shifted now to where we've got more cases out of Europe, over 170,000 of those cases, and it's just explosive in Europe, and we'll come back to that. In the U.S., now that we're up to getting our testing going and all, we are at about 40,000 cases as of today, about 500 deaths. But that 40,000 is double what it was 48 hours ago. Some of that is testing. A lot of that may be testing right now, that we're finally getting the testing in. But it's also the epidemic. So if you look where it is in the U.S., and I think we've all probably seen this, at least 15,000 of those cases are in New York. So that's actually, I think it's now up to 25,000. But it's New York and Seattle and California. And it's continuing to double. So it's on the up curve. And that's what we're really looking at is the up curve. So how are other countries doing? Japan and Singapore have had a good response, and they're actually doubling about every 10 days. So it's still growing there. US and most of Europe is doubling every 2 or 3 days. Italy, Iran, Spain, 2 days about 2 days. So it really is on the up curve. The goal at this point is what we call flattening the curve. So when you get this huge upstroke, that's when hospitals get overloaded, and epidemics like this kill 3 ways. One is the disease itself, the virus itself, and the complications of that. The other is that when health facilities are overloaded, then basically the other parts of healthcare get a hit, and the resources are diverted. So, for example, in the West Africa Ebola outbreak back in 2014, 11,000 people died from Ebola, and 10,000 from the disruption of malaria services, maternal and child health. So we're worried about the virus, the disruption of health services, and also the economic impact. It's not just money, it's lives and livelihoods. And the financial crash cost at least of 2008 cost at least 250,000 lives, probably double or triple that in terms of lost health care, suicide, and things like that. So what we want to try to do is to slow the rise so that we what we call flattening the curve. And so what that does is it manages the load on the health services and gives us time to get a vaccine, and a few other things we'll come to later. So China has been able to level it. The other country that's been able to level things is Korea. And so they've gotten down to where they're at a pretty constant level of new cases where they could really manage that. And they've done that with consistent messaging, with rapid setup of drive-through testing, which was instrumental. They were doing multiples of our tests all along. Shared GPS coordinates of who's infected. That's be tricky in some places. Costume people in public places, reminding people about washing hands, which is really effective. And they also had a culture, and they had a practice because they'd gotten hit by one of those earlier coronaviruses. So, so that's kind of the state of where we are. The epidemic is still accelerating, especially in Europe, and now Europe's taken over as the lead, and North America coming up. And still only one really good example of an open society country that's managed to level it off. So let me take a few of the questions before we talk a little bit more about where this came from. And I may pass on some of these if they lead to something else. What's our testing strategy to know? Right now, I mean, we're tracking the outbreak by confirmed cases, tested cases, and at least now in the U.S., those are basically people who are symptomatic. What you want to do is test anybody who's been exposed or symptomatic, and ideally we'll get to that. By the way, testing itself puts people at risk because consumes a lot of materials until we get to where we've got self-administered, which we're getting close to, where you can put a swab in. The simple act of protecting the health worker to test somebody consumes materials. So the tests are being used right now in a strategic way for people who are symptomatic that we want to confirm. And also we'll do other tests, flu tests, to see if there's another disease that is affecting them. Yeah, I think what I'll do is go through the next parts, and then some of these questions may get answered. And Marion, are you also able to look at the questions and see a little bit what ones, as you're listening, might be useful to come back to?
Yes.
Okay. All right. Okay. So let's talk for a little bit about how it got here, and a little bit more about why we're so worried about it, and then the trajectory. So, like 3 out of 4 new human viruses, this came from an animal to human species jump. AIDS came out of Africa 100 years ago, worked its way slowly, and actually didn't explode into a major epidemic for about until the 80s. The Ebola virus, which caused so much trouble, that was also from a bat to human. The Zika virus, which is mosquito-borne, that got into Latin America 4 years ago. All of those are a species jump. We've talked about the coronavirus family, and what's been different about this one is it's both highly deadly and highly contagious, and it came at the worst place at the worst time. It came just before. It came at the large city in China, where it's at the crossroads of waterways and airways, just before a major holiday, in which it really got spread out. And this is where time really matters in epidemics. Had it been caught earlier and before that, we might have had quite a different story. There's a lot of discussion about this, the coronavirus versus influenza in the number of cases. It's not just the contagiousness, but it's also the deadliness. So with flu, 1 in 1,000 people on average die from flu every year. With this virus, it's about 1 out of 100. And remember, we've only known this virus for now just close to 3 months. So there's a lot that we don't know about and a lot that we know. But basically, we're seeing about 1 to 2% overall. So it's 1 in 100, but it's 1 in 10 for 1,000 cases in the U.S. Half of the intensive care, nearly half of the intensive care unit admissions were in people under 65. So it does hit across the ages, but still disproportionately, it's the older folks. So that's a little bit more about the virus and where it came from. So the question that people are asking now that it's shut down major parts of the economy is what next? When does it end? So that depends on 4 things. It depends on the virus behavior. Is it seasonal and is it going to mutate? So will it go away in the summer like the flu virus? Again, the coronaviruses have acted differently. There's some really good reasons and some evidence coming out suggesting that it may well take a downturn during the warm months. Most of the virologists that I am aware of are of the view that there is so much of this virus everywhere that it's not going to go away. It may go down in the summer, and that would be a good respite, but it's not going to go away on its own. The other thing is the possibility of mutation. Some viruses like flu mutate a whole lot. This one tends to be more stable, but that's also makes the sort of end game unpredictable. So that's one thing that's going to tell us whether it's going to end. The second thing is vaccine development, and pretty consistent message coming out of the vaccine development folks. I mean, the good news is there are at least 3 dozen vaccines, potential vaccines. At least one's already gone into human trials, but it's going to be 12 to 18 months. And success is not completely assured. Just again, it's a matter of finding the right way to attack the virus to stimulate the immune system to develop antibodies to it. The third and fourth factor are leadership, consistent government and public-private sector, everybody with the messages about social distancing and all. So it depends on consistent leadership, and I'll come back to that, and also on our own behavior. So they're basically out of this, in essence, 4 scenarios. One is that it goes away in the warm weather, unlikely to be a permanent thing. The vaccines, 12 to 18 months. The third scenario is that we get enough of the population that gets immune, that gets infected, that survives and gets immune, and gets natural herd immunity. It's like being immunized by the virus. And with a virus like this virus, that would take about 60% of the population and to be immune. That would, the modelers estimate that would take a couple of years. So the last scenario is basically that we apply vigorous methods as we are doing now to control the spread of the virus, get it down to a manageable level, and then hopefully be able to really bring back online, as it were, the economy. It's not going to go away in 15 days. What we do want to do in 15 days, with all this vigorous effort, is to get the number of new cases down in such a way that we actually can manage the burden in the health system. Let me see if there are questions on that part of it. Okay, yeah, good question. Okay, why does vaccine development take so long? It's it's the development and also scaling up the production and the distribution. And that's an average based on the process that you go through to make sure that the vaccine is safe, that the vaccine is effective, and you only really know when you do human trials, and that's a process that's difficult. Oops, hold on a sec. There's a lot of good news in terms of how quickly we moved, because we've gotten from the virus to the genetic code for the virus to a candidate drug in record time. And so that's the good news. But it is just the number of cases over time to get the safety of it, to get the effectiveness of it shown, and then to get it scaled up in production. Vaccine production is a very specialized area. You can't just run flu vaccine in a factory until Friday, shut it off, and start on coronavirus vaccine on a Monday. And so there's a lot of planning that has to go into making that happen.
Jono, Fred Adair asks, are there efforts underway to improve treatment methods near term in the advance of development of a vaccine?
Yes. There are several dozen now potential medical treatments, antiviral treatments that could be used to treat the virus and reduce the complications. And those also are going into clinical trials. The World Health Organization is overseeing and is coordinated for those that are going to be starting up. And that's another thing that has gone very quickly. So the regulatory authorities have partnered with the pharmaceutical industry, the producers, in order to streamline the process. And this faster way of getting products into production, into testing, is one of the outcomes of, again, the Ebola outbreak, where there was a lot of trouble getting going on research to begin with. And it's by no means perfect, but it's moved along. Another question that you think is appropriate on this side?
Well, I'm just going to go through them.
Okay.
Henrietta Wigglesworth Lodge asks, if many people who have the virus are asymptomatic, shouldn't everyone be tested in order to have the accurate number, help healthy people have a reason for social distancing, and provide numerous avenues for research on vaccines, treatments, etc.?
Well, we're not at the point where we actually have the tests to do that. And I think that's one of the challenges of scaling up the testing. And ideally, that would be nice to be able to everybody be able to do their swab and get the test. We're not there yet.
Ryan O'Connell asks, the president seems to be saying in his press conference tonight that people may start going back to work in 15 days. Does that seem risky to you?
Well, I'd be interested to know what that's based on. We will not see we're not going to see we're still on a growth curve. And so what we don't want to do is get people coming back and accelerating that growth curve. So that seems a bit of a stretch right now.
Okay. There are a couple of personal questions which I will address in a minute because they're very important. But right now, Stu Berman asks, why couldn't the U.S. have just used the COVID-19 tests that the Asian countries are using?
Yeah, good question. I haven't looked enough deeply into the test to know. I have the same question. Because they started off with a rapid turnaround test, and that was that's one of the factors that that people attribute their success in leveling off the curve to. Yeah.
Valerie Nelson doesn't question but comments, President Trump is now talking about reopening the country for business, that the costs of social distancing and closing, including to health, are worse than reopening.
So I think that's a debate that has to happen. I have the same concern, and it relates to what I was saying before about it. It's not like you can choose to save lives and closing the economy, as if that slowing down the economy costs lives and livelihoods also. So I think what we need on that is a dispassionate, evidence-based debate. I would love to see a classic debate where you get two teams, doctor and economist, doctor and economist, a sort of pro and con for how we get back. That's the kind of just dispassionate debate that we need to have. And other countries, I mean, UK has taken a slower approach to closing things down, and they were following a sort of a herd immunity philosophy that it's okay to let a certain amount of disease go. But they've been, I mean, that said, have had a smaller outbreak. So I think those are all fair questions for which I'd like to see us have the kind of debate to get to a good answer for those.
Sarah Kuhn asks, I've heard about patients crashing well into the course of the illness when they seem to be recovering. Is this true?
Well, yeah, I mean, that's not uncommon where you think things are coming back and then there's something smoldering that catches up to you. That's not uncommon. The other thing that we need to watch out for is we know with the SARS virus, a quarter of the people who survived had lasting lung trouble. So we're going to have to just see how once people are recovered, how fully they recover.
Ron Diekman asks, what do you think is the likelihood of successful specific antiviral treatment?
I mean, antiviral treatment has been variable in its success. So, I mean, that said, I think I'm hopeful, given the number of different products that are lined up to be tested and all. I'm hopeful that it will at least mitigate the disease for enough people that it makes a difference, that it saves lives. I'm hopeful on that.
I'm going to now, I'll go back to some of these more broader questions, but there are a couple of people who have asked very specific personal questions. And the first one is about Wendy Cutler asks if her daughter is jogging in New York and somebody sneezes near her, what the issues are. In other words, is it safe to be outside working? I think she perhaps works outside in New York.
Well, yeah, I mean, it is. So if you look, well, maybe we should go on to that. While we're on that, let's just go on to that part of it. I mean, the principles about, I think we've heard it a lot, but the principle about hand washing, keeping 3 to 6 feet apart, limiting the time, limiting the hand to face. And I mean, yes, if somebody's infected and sneezes, that's one of the things you don't want to have happen. So that's why you want to keep your distance.
Okay, Rick Weil asks if somebody's had it and recovered, can they get it again, give it to others? Is that known?
Yeah, so that's what, again, because it's a new virus, that's one of the things we don't yet know is how long the immunity lasts. And when we have big outbreaks, it takes a while to understand that process. The good news is that we have not, until just this last week or so, had an antibody test that would let us see if they had at least developed antibodies to the disease, and then we could track that. So there'll be some large-scale tests going on to find out how long immunity lasts.
Okay, now this is a long question, and I hope I understand all the words. So it's clearly more technical than I am. I find myself, this is from Jonathan Sprague, I find myself thinking about the next pandemic as much as I do this one. For at least 2 decades, zoonotic spillover has been established as the source of most recent pandemics, and critical intersections of humans and live animals are found in China's wet markets, especially those selling wildlife. Apparently, 80% plus of all poultry consumed in China is bought live. Thailand, Vietnam, and the Philippines are commonly sell live or recently slaughtered meat in the wet markets. What serious initiatives However, ambitious or diplomatically tricky can be engaged to curtail this custom in order to avoid or at least delay the genesis of the next pandemic.
So I think that's at the heart of this whole idea of making the world safer for these pandemic threats, and that's the core of what we talked about in the end of epidemics. The problem, the challenge is that we've had international rules, the international health regulations for 50 years that say what countries could do, should be doing to make themselves safer. But we have never defined that in a clear and concrete way so we can measure who's safe and who isn't. And finally now, just over the last 6 months, 6 months ago, we have the first global health security index that gives a scorecard for each country on how they're doing with prevention, with detection, with response, health systems, the environment, and all. And what we know is that only 1 out of 4 countries worldwide is up to the task. And so we now have a scorecard that you can look and see which countries are safe and which aren't. People have been ringing the bell about this for decades, and we're in this cycle of panic and neglect, and it's a deadly cycle. So what happens is, and I'll give you a good example. After 9/11, this is going to be a long answer to a very important question, which is how we got here in the first place, because that outbreak, that we knew that there were going to be coronaviruses. That was one of the public enemies number one, the viral public enemies number one that we were watching. We expected that there would be a virus like this that would come out, and that's in the biology of things. As Louis Pasteur said 100 years ago, the bugs will always have the last word. Well, okay, these outbreaks, local outbreaks, are inevitable. But the difference between a local outbreak, and like we had at the beginning, and this catastrophic pandemic is more often than not human action, or more often inaction. And so what's happened is, for example, after 9/11, the U.S. government, the Congress, created $1 billion public health preparedness fund, emergency preparedness fund. It slowly got defunded. We had the bird flu in the mid 2000s, and it went back up again. Then we had the financial crash, and it went back down. And then we went through 6 years of defunding our public health service through all of this. We lost 45,000 health workers. The problem with our slow response didn't start in January. It started a decade ago. And it's because when we had the outbreaks, we panicked, we did stuff, but then we got complacent. And so I think that it's us understanding what's at stake. And, our political leaders tend to respond to whatever's kind of on our voting minds at the time. But I think that one of the communities that has a really important role is the business community, because they're the ones who benefit the most from a safe environment, and have the most to lose for an unsafe environment. I mean, the Ebola outbreak knocked out the mining industry. This pandemic has hit a bunch of industries, pretty much as predicted by the modelers. I mean, Homeland Security, 5 years ago did a scenario exactly like this. They had the evidence, but if you look at the funding, we're getting about half of what the legislation back in 2012 that put this in said we should be getting. So we have got to accept the fact that we've got a more complex world. It's a riskier world, and we have to invest in making ourselves safer in this world. So that was a long answer to a short question, but I think we got to deal with the current outbreak, but we also need to think about and remember the moment and think about how to prevent the next one.
Ken Bolliard asks, please ask if the frontline medical staff should have masks. This is contrary to what the CDC has apparently indicated. What is your take on this?
Well, I mean, you need to be protected if you're seeing anybody who's exposed or has the disease. I'm not sure. There is sadly, there's a rationing going on, exactly because the surge supplies and the stocks that were budgeted for and known to be needed weren't funded. That's just the reality. And so people any health worker that is seeing somebody who's exposed and a question of having the disease or is taking care of that person should have the adequate protective gear.
Bart Sachs asks, are you going to discuss the science of viral illness? I have read about multiple organs being affected by the viral illness.
Oh yeah, no, I wasn't going to go into that, but that is, I mean, it's kind of, yeah. I mean, you can. That's something I would. There's some good sites online you can read about that. The key thing is, I mean, the virus really attacks the lungs and breaks down the lungs defenses, and the most common ultimate killer is a bacteria pneumonia that gets in because the defenses are broken down. And that's why having the pneumonia vaccine, even though the coronavirus is not a bacteria, the pneumonia vaccine doesn't work against the virus, but it works against the bacteria infection that ultimately could kill you. So that's a reason to keep up on your immunizations.
This, I think, leads into your final topic. And Theodore Shasta asks, going forward, after this pandemic has passed, what must be done? Do we need structural changes at the federal and state levels? How do we avoid politicizing these changes so that science holds the upper hand?
Yeah, so I think what we know is in order to win against a major pandemic like this, it's got to be a whole of society response, a whole of government response with one team, one plan, one message. And so part of that is to have somebody, because ultimately it's a national security issue and it's a health issue. And so there's part of the cycle of panic and neglect is there. After you have a big thing like 9/11 or Ebola, as soon as that happens, the president, doesn't matter which party they're from, the president puts a senior person on the National Security Council who is their pandemics person or pandemics and bioterror person. And they can look out for, they can keep an eye on the funding and the threats and make sure that we're getting prepared. What happens is then the next president comes in, and this has happened over and over again. I mean, I can give you, the next president comes in and says, well, this National Security Council is all kind of, it's too big. So then they bury this person down below, and then they don't have the authority to keep ringing the bell. That's one thing that I think is really important. The other thing, there's some organizations like the Trust for America's Health that look at this data and say, this is a real risk. And I think we've got to develop a movement around this. So you need leadership in the right place. We need to continue to invest in a strong health system. And the other thing is innovations. And so coronavirus was one of the viruses that was on WHO's top list to get for research and development, but we weren't investing. So we, in the end of epidemics, we look at what it would take to make the world safer from these outbreaks. And I think we probably estimated low before we came out $1 per person per year. It's probably $2 per person per year, but $15 billion a year for 20 years is a pittance compared to what it costs when we have outbreaks like this. And so about 2/3 of that is actually strengthening the ability of countries around the world, like China. I mean, I had talked about this Global Health Security Index. It's a 0 to 100 scale that 191 countries are rated on. Korea, which has done well with this, they were a 70 in the green zone. China was like less than 50, and many countries are. So investing in working and supporting other countries. I mean, this is global. This is not all U.S. money going into that for that 15 billion, but we need to globally get that money invested, and then we need to do research and development on vaccines, on the antivirals, and on more economical and scalable protective equipment, and then a small amount for emergency response. So making the world safer is actually a really good buy.
So there are two medical questions. One is, as a general question, what data exists on COVID-19 in young children and babies versus young adults and boomers? So why don't we do that one, and then I'll ask the next one.
Yeah, I've not looked at what the latest is on that. I mean, one of the questions is they seem to be, well, they do get the infection, but they seem to manage it much better, and that's a little bit of a paradox in the sense that with some of the other viruses like flu, it does tend to hit the younger kids. But I have to say, I'm not up on the latest on that. By the way, this is a really fast-moving field if you haven't figured it out. There are some, and I can give you these lists. There are a couple people who are doing really good updates, and I'm happy to do a list for folks of the best updates in at least a couple of the fields.
We can share that.
Yeah.
Terrence McNally writes, from what I've gathered, most of the deaths are from cytokine cascade or sepsis.
Oh, yeah. Okay. Yeah. Cytokine storm. What happens? So the death from a viral illness like coronavirus can come in a couple ways. Let's say from a bacteria infection that causes a pneumonia or gets throughout your blood is sepsis. The other thing is that, and this is something we do see in influenza and know it well, is that when you get a robust immune system, as you have in younger people in the in-between ages, you can get an overreaction of the immune system, a sort of a overexuberant response to the virus, and that actually ends up filling your lungs with fluid and ending up causing the death yourself. So it's called a cytokine storm, and it's just setting off a chain reaction of your own defense that just goes into overdrive, and sadly it will kill a certain percent. I have not seen the data on coronavirus that breaks that out, though.
Jonathan Sprague asks about present drugs in development, and are there older drugs that can be repurposed?
Yes, indeed. Some of the clinical trials that are getting going are using some well-known anti-malarial drugs, and there are. I mean, that's just one example, but the answer is yes. Those are some of the drugs that are going into clinical trials now.
And Fred Adair asks, what do we know about people who could be infected and have no symptoms? How long could they have it before it goes away? How infectious are they during that time? Yeah,
in general, the belief based on what data we do have is that the more symptomatic people are the greater spreaders. And part of what makes this coronavirus more contagious than others is that it's not just lower, but it's an upper respiratory shedding of the virus. So in general, the belief is that people who are flagrantly symptomatic are bigger spreaders.
Those are the questions that I can see so far. I think we've gotten to virtually all of them.
Oh, okay.
So you can go along and oh, no, here. Ted Theodore Shasta says, thank you very much for your time and efforts. Highly informative. Is it possible to organize so as to push our government in the right direction and maintain oversight, political pressure over time to keep our leaders focused? Perhaps a subject for another time, not to be answered at this time. But would you like to discuss that?
Well, yeah, I mean, I think we need to keep pushing because, and again, this is, unfortunately, there's a dynamic, another one of the things we talk about in the book, of the economics and politics of now. And so it is, and part of it is the way we vote. So voters do not vote for office holders who make a big deal of prevention. They really hammer at the ballot box leaders who were seen to have missed a disaster and not managed it well. So it's partly the interest that we take in this. But I do think that getting this on the agenda, and again, the business community. I mean, if I was a businessman or an investor going into any country, because most of these, as it's turned out, most but not all have come elsewhere. First thing I'd want to know is what's their score on the Global Health Security Index?
Why aren't we hearing about this illness in Africa and South America, Bart Sachs asked.
So, indeed, and there are three possible reasons. One is that the flight paths just haven't been intense enough to take it there. The second is that we haven't heard about it because the testing isn't being done, and I haven't seen numbers on testing. The third and most hopeful is that it's warmer down there, and that may be protecting them. And if it's protecting them, then it would be a benefit to us when we get into the warmer weather. And I haven't seen a good explanation of that yet.
Donna Brorby writes, in retrospect, how well or poorly has China handled this outbreak? They initially shut down doctors raising the alarm, but then they pretty quickly identified and shared the genetic structure of the virus. And she says, my bias is to be outraged by blaming the Chinese, but...
So what happened there, I mean, the answer is some of both. It definitely, and it seems, my reading of it is it happened at the local level, was that it was just reflex, tamp down, all of that. And that's a common reaction in a lot of places. It's not just in China. And part of it is that we have, like in this country, probably every public health department can find in their files somewhere a pandemic preparedness plan, but they never practice it. That's one of the weakest things on this international scorecard is practicing it. And so my sense is that there were, I know, because I know that some of the folks, there were people in the Chinese Center for Disease Control and in the health system, good professionals who knew exactly what should have happened. But that's not what happened at the local level, and that was as far as I can understand, a pretty classic reaction of the ministry there. And that's the time to get it. Time is such a critical factor in outbreaks, and so that was a problem. I think that said, once it became apparent, I think they're just really. I mean, people use the word draconian. I mean, that clamp down certainly, once it got going, got it in control so far. Well, got it down. It's still working at lower levels. So I think that the second part of the response, when they really clamped down, did save it from being worse.
Jono, we're beginning to run out of time. Do you have some wrap up that you would like to provide?
Well, oops, have I lost you again?
No.
Okay. Well, I think I've kind of shared the main messages, which come down to, I mean, remember this moment. I mean, I had never in my, even though I wrote about it, I talked to people, I'd seen what happened in with the Ebola outbreak. I mean, it is the worst imaginable epidemic cascade where you have the disease, it disrupts schools and other things, it disrupts businesses, it disrupts the economy, and it has this lasting effect. But yeah, outbreaks are going to happen, but I don't believe that something of this magnitude was inevitable. And I do believe, even more now, that the 7 key things that we laid out in the end of epidemics give them major things that have to happen in order to make the world safer. And so I know that we're going to get through this, number one, and I know that history suggests that we're probably going to forget it quickly. And that's my biggest hope, is that we don't, and that we at least enough of us really say, you know, I don't want this to happen. And I also want us to ask ourselves, are there other threats out there of comparable magnitude that you know, experts have been warning us about, and people who have, you know, no agenda other than to find out, you know, what does the science say about what's likely to happen? Are there other things out there that we're being complacent about? Are we going to leave another whammy on our children and our children's children? So I think that's my main message, is remember this moment, because it's something we can do to significantly reduce the chances of facing it again.
Thank you.
Thank you, Jono, for answering so many questions and for providing so much wonderful information. We're really indebted to you. If you all who are on the call want to learn more from Jono, order his book, The End of Epidemics. Also, ClassACT is considering hosting more sessions like this one in the near future. If you have a suggestion for a topic or a classmate expert, please send us an email and we will consider it. In the next week, ClassACT will be creating a COVID-19 page on our website. We will also introduce a discussion group that will be open to all members on the website. Please let us know via email what you'd like to see on that page when it's up, and please join the discussion. Also, if you're just interested in learning more about ClassACT and how you can become actively involved, visit our website or send us an email. ClassACT is built on classmate participation, and we're interested in having every classmate as a member of our ClassACT community. Once again, Jono, thank you so much. And to all of the rest of you, may we all be well and safe. May we find ways to help others as we move through these hard times. Good evening to all.
Night all.
Thank you. Bye-bye.
Bye.